Welcome to your educational module on expanding SBIRT to address smoking, depression, and anxiety. Hello, my name is Rich Brown. I've helped numerous primary care settings implement the evidence-based services I'll talk about in this video. I'm so glad you've tuned in because these services could help so many patients. In this module, you'll hear about the rationale for expanding SBIRT to address smoking, depression, and anxiety, the screening and assessment tools available for these topics, and evidence-based methods of intervention and follow-up. Many slides in this video carry more detailed information than I will speak about. Feel free to pause the video at any time so you can spend more time absorbing the information on the slides. I'll start with an in-depth explanation of why it makes sense to expand SBIRT to address smoking, depression, and anxiety. There are at least 6 reasons. One reason is that smoking, depression, and anxiety are quite prevalent among our patients. SAMHSA's National Survey on Drug Use and Health in 2019 found that nearly 22% of American adults smoke cigarettes. The prevalence is a bit higher in males than females. It's especially high among American Indians, Alaskan Natives, and people who describe themselves as multiracial. People who smoke tend to have less formal education than non-smokers, though still about 1 in 9 college-educated people smoke. People who are unemployed have an especially high prevalence. The same national population survey found that about 8% of American adults had depression at some point in 2019. On the graph, the height of each bar indicates the total prevalence. The dark blue part of each bar shows how many people got at least some treatment. The light blue part of each bar shows how many people got no treatment. Depression is more prevalent in females than males. It's especially prevalent among people who call themselves multiracial. Treated and untreated depression are more prevalent in people with lower incomes, people who are employed part-time or not at all, and in people who had some college education but did not graduate. The prevalence of depression is quite high among patients with Medicaid. Not surprisingly, the prevalence of untreated depression is especially high among people with no health insurance. Depression is strongly associated with worse health. The National Survey on Drug Use and Health does not cover anxiety disorders, so prevalence data on anxiety are not as detailed or recent as data on depression. Between 2001 and 2003, the prevalence of anxiety disorders was about 18%, and only 37% of people with these disorders got some treatment. Here you can see the prevalence data for 4 kinds of anxiety disorders. Post-traumatic stress disorder and obsessive-compulsive disorder were previously considered anxiety disorders, but now they are not, so this presentation does not focus on those disorders. In summary, smoking, depression, and anxiety are quite common among American adults, and especially among certain racial minority groups and economically disadvantaged people. Another reason to expand SBIRT to address smoking, depression, and anxiety is that these conditions exert many important negative impacts. Smoking is the leading preventable cause of death in the United States, killing nearly 500,000 Americans per year. Smoking significantly increases the probability of developing these 4 diseases, which are frequently fatal, and many other health conditions. Smoking increases the risk of hospital readmissions for patients with heart failure and many other conditions. Healthcare administrators are especially concerned about readmissions that occur within 30 days because Medicare imposes significant financial penalties for high 30-day readmission rates. For patients who have many different kinds of surgery, people who smoke have much higher chances of serious complications, including death. Smoking is a strong predictor of poor outcomes for hip replacement surgery. Depression also exerts many negative impacts on health. According to the World Health Organization, depression is the leading worldwide cause of disability. Studies show that depression leads to more hospital admissions and days in the hospital, and more readmissions for heart failure, myocardial infarction, and pneumonia. One study found that even mild symptoms of depression predisposed to higher 30-day readmission rates. In one study, which considered 29 demographic variables and clinical conditions, including obesity and diabetes, depression was the strongest predictor of the need to take hip replacement patients back to the operating room for repeat surgery. There has been less research on the health impacts of anxiety disorders, but those impacts seem significant as well. Among patients with chronic obstructive pulmonary disease, those who have an anxiety disorder have 40% more exacerbations than those without. Anxiety is associated with a higher incidence of coronary artery disease and higher death rates as well. Among patients with heart failure, those with anxiety adhere less to their medication regimens and have more emergency room visits, hospitalizations, and deaths. The high prevalence and terrible impacts of smoking, depression, and anxiety are strong reasons to implement systematic screening and robust intervention for these conditions. Another reason to expand SBIRT is that validated screening and assessment tools are available for these conditions. Before we talk about that, let's take a minute to differentiate between screening and assessment. Screening is very brief, so that it's feasible to screen all patients who come to busy primary care settings. Screening is intended for all patients, including those without apparent symptoms. Assessment takes longer and is intended for patients with known symptoms or positive screens. The aim of screening is merely to identify patients who might have a disorder and should therefore undergo further, lengthier assessment. Assessment indicates the severity of patient symptoms and their likelihood of having a disorder. The most commonly used screen and assessment for anxiety are the GAD-2 and the GAD-7. For depression, the PHQ-2 and the PHQ-9. This slide summarizes the accuracy of screens and assessments for the three conditions. Sensitivity indicates the likelihood that patients with the condition will have a positive screen or assessment. Specificity indicates the likelihood that patients without the condition will have a negative screen or assessment. Experts agree that the accuracy of self-report for smoking and the screens and assessments for depression and anxiety are sufficient for clinical use. Of course, it wouldn't make sense to screen systematically for a condition that is untreatable. Fortunately, there are very effective interventions and treatments for smoking, depression, and anxiety. Here's a summary of conclusions from the Federal Tobacco Cessation Guideline published in 2008. In clinics where patients are not screened for smoking, the one-year quit rate is about 3%. We can consider 3% the baseline natural quit rate for the general population. In clinics that do screen and then intervene in a non-systematic manner, that quit rate doubles to 6%. In clinics where patients are screened and those who smoke received optimal care, the quit rate increases as high as 28%, almost 10 times the natural quit rate. What does it take to get that huge treatment effect? It takes medications to treat nicotine dependence, 9 or more one-on-one support sessions, and if the patient is amenable, participation in the smoking cessation group. Studies conducted since then have found that we can increase quit rates further by using motivational interviewing to help patients who are not ready to quit become ready. How many of our patients who smoke receive these optimal services for the leading cause of preventable death in the United States? Sadly, very few, if any. From a public health standpoint, the lack of robust smoking cessation services is arguably the largest failure of our healthcare system. Before we look at the data on treatment effectiveness for depression and anxiety, let's talk about numbers needed to treat, or NNT. NNT is the best numerical way to indicate how effective a treatment is. NNT is defined as the number of patients who need to be treated to achieve a particular positive outcome in one patient. So, if a treatment attains a particular benefit for 50% of those treated, the treatment would have an NNT of 2, meaning that 2 patients have to be treated in order for one patient to attain the particular benefit. A treatment that is effective for 25% of patients would have an NNT of 4, meaning that 4 patients need to be treated for 1 patient to attain a benefit. The lower a treatment's NNT, the more effective the treatment is. NNTs are typically calculated from many studies on a particular treatment. Such studies often show that treatments are not as effective as many people think. One well-studied treatment is zinc lozenges for cold symptoms. The NNT is 5 for symptom reduction on day 7. Some of the most widely recommended treatments have NNTs that are quite high. 18 for the Mediterranean diet to prevent repeat heart attacks. 36 for high-dose steroids to prevent death in patients with COVID-19 pneumonia. 61 for the Mediterranean diet to prevent heart attack and stroke in healthy people. And 100 for blood pressure medications to prevent a heart attack in people with hypertension. With all this in mind, let's now take a look at the effectiveness of treatments for depression and anxiety. This table summarizes the best available information on the effectiveness of 2 different kinds of psychotherapy and several kinds of medication for depression and 3 kinds of anxiety disorders. Notice that the NNTs, where available, as shown in yellow, are quite low, lower than many of the widely recommended medical treatments on the previous slide. In other words, depression and anxiety disorders are highly treatable conditions, more treatable than many physical conditions. This is important information for the many patients with depression and anxiety who doubt that medication or counseling can help them. Sadly, just as for smoking, few patients get treatment for depression or anxiety that could be so helpful. The latest data we have on this goes back to 2001 to 2003. Almost half of depressed American adults received no treatment. Only 1 in 5 received both medication and counseling as recommended by experts. The numbers are similar for patients with anxiety disorders. The effectiveness of treatment for smoking, depression, and anxiety, and the large number of patients who don't receive optimal treatment are strong arguments for expanding SBIRT to cover these behavioral conditions. Another reason is patient acceptance. Patients readily complete screens for these topics in primary care settings when certain strategies are employed. One is calling the screen a form rather than a survey or questionnaire. Patients are used to filling out forms in healthcare settings. Forms are routine. Many patients are more reluctant to complete paperwork that's called a survey or a questionnaire, which seems more optional. Another helpful strategy is to frame the screening form as routine care so patients don't feel picked upon. A third helpful strategy is to order screening questions on the screening form from less sensitive to more sensitive. The order of screening topics might be cigarette smoking, anxiety, depression, alcohol, and drugs. This brings up another benefit of expanding the scope of SBIRT. Including screening questions on other health concerns helps patients feel more comfortable responding to sensitive questions on their drinking and drug use. Most patients are very satisfied with counseling for depression and anxiety when it is delivered as experts recommend. Nevertheless, it can be challenging to help many patients initiate such counseling. Here is a list of patient perceptions that can hinder their initiation of counseling. Stigma includes concerns about being judged and a sense of shame of not being able to solve problems without help. Lack of energy and motivation to get help are common. That's especially true for people with depression because symptoms of depression include a lack of energy and motivation. Emotional concerns include preferences not to talk about sensitive issues or be around other people when upset, especially people who patients don't know well. Negative evaluations of therapy can come from previous personal experience or negative reports from family members, friends, or other acquaintances. Misfit of therapy to needs includes perceptions that therapy won't help patients with their problems. Time constraints can relate to work schedules or obligations at home. Participation restrictions can include transportation barriers and symptoms or illnesses that make transportation difficult or uncomfortable. Sadly, in most communities, especially for patients with Medicaid or no insurance, it can be difficult to access high-quality counseling in a timely manner, if at all. Primary care settings can help overcome these barriers for many patients through a combination of patient education and motivational interviewing. It can be especially helpful if such settings can offer counseling on-site and arrange warm handoffs, brief introductions of counselors to reluctant patients, which often breaks the ice. The last part of the rationale we'll discuss for expanding the scope of SBIRT is to increase stakeholder support. Some stakeholders who express limited support for SBIRT are more enthusiastic about a program that also addresses smoking and mental health disorders, because it will be even more effective at improving health, reducing hospitalizations, and decreasing healthcare costs. Stakeholders who perceive that alcohol and drugs are outside the purview of general healthcare settings may perceive smoking and mental health disorders as more in the purview of those settings. I hope you agree that the rationale for implementing an expanded SBIRT program is very strong. Now let's talk about evidence-based methods of doing it. First, we'll cover screening. Here is the PHQ-2, which screens for depression. As in the PHQ-9, GAD-2, and GAD-7, each of the questions asks about the frequency of symptoms over the past 2 weeks. It's important to emphasize to patients to keep the entire last 2 weeks in mind as they answer each question. For all 4 questionnaires, scoring involves adding up all the points for the response to each question. For the PHQ-2, a score of 2 or less is a negative screen. A score of 3 or more is a positive screen, indicating that the patient might have depression and should undergo further assessment. Here is the GAD-2, which screens for anxiety. Scoring and interpretation are identical to the PHQ-2. Next, we'll focus on assessments. Here's the PHQ-9, the most commonly used assessment questionnaire for depression. Notice that question 9 pertains to suicidality. If the patient's response is anything but not at all, the patient must urgently undergo a more comprehensive suicide risk assessment. This is an important step in the workflow for primary care sites to consider when implementing a depression screening and intervention program. A key question sites need to consider is who will do these suicide risk assessments. Scoring and interpretation of the PHQ-9 is very straightforward. The key number to remember is 10. A score of 10 or more should trigger an intervention, collaborative care, which we'll talk about in a few minutes. Here's the GAD-7, which is similar to the PHQ-9 in form and structure. As for the PHQ-9, a score of 10 or more should trigger an intervention. Now let's focus on interventions and follow-up. For smoking, contrary to popular belief, we should not wait for patients to express readiness to quit. We can use motivational interviewing to help bolster readiness. Motivational interviewers avoid giving unwanted information and advice. Most people who smoke already know it's bad for them. Education on the health-related harms of smoking rarely leads to quit attempts. It's often helpful to ask patients about their reasons to keep smoking, what they enjoy about it, or how it helps them. This is an opportunity to convey empathy and demonstrate that you will not try to persuade patients to quit. People don't like to be persuaded, and persuasion usually does not work. After briefly discussing the positives of smoking, most patients will readily discuss the downsides of smoking and possible advantages of quitting. Motivational interviewers respond by using reflections and open questions to strengthen and deepen patients' reasons to quit. A similar approach is used to help bolster patients' confidence to quit. After several minutes, it's time to assess patients' readiness to change in light of the foregoing conversation. If patients are not ready, we accept that, thank them for their willingness to participate in the discussion, and leave the door open for future discussion. The same approach can be used to help patients find motivation to quit or cut down on drinking and drug use, or to change other health-related behaviors. For patients who are ready or committed to quit, We help them develop a personal behavior change plan. The motivational interviewer frames the discussion and, if asked, suggests options. The patient makes the decision on each potential element of their plan so that their plan reflects their goals, values, resources, constraints, and preferences. The first element is limits. Research has shown that sudden quitting yields the best results, but some patients may choose to cut down or gradually taper. Next, we ask patients what tends to trigger them to pick up a cigarette and how they could avoid those triggers or respond to them without smoking. Next, we ask patients to consider alternative behaviors, things they could do to make it easier for them not to smoke. For example, they could involve themselves in new activities in places where smoking is prohibited. We help patients consider how to change their environment to make it easier not to smoke. For example, they might choose to get rid of their ashtrays, matches, and other cues to smoke. Social support can be very helpful. We help patients consider people they could talk to support their efforts, such as loved ones, friends, and others who have quit. Social supports can also include smoking quit groups. Patients who take medications for nicotine dependence are much more likely to succeed at quitting than those who don't. We educate patients about those medications, ask if patients are willing to consider them, and if so, connect them with appropriate resources. It helps many patients to set rewards for themselves for sticking to their plan for a certain amount of time, and we help patients make those plans. We also ask patients to consider contingency plans, what they could do to avoid smoking if they find themselves about to pick up a cigarette. Finally, we ask patients to set a time for follow-up. At those follow-up visits, we collaborate with patients in assessing how well their plan and each of its elements are working and strengthening weaker aspects of their plan. We iterate this process over several weeks or months until the patient no longer needs our support. This sounds like a large time commitment, but remember that overcoming nicotine addiction is difficult, usually requires lots of support, and pays off in huge health benefits and healthcare cost savings. The most effective approach to addressing mental health disorders in primary care is called collaborative care. Typically in primary care settings, the primary care provider makes the diagnosis, prescribes medications, and offers emotional support. The PCP might also attempt to refer patients to a counselor or a psychiatrist. Collaborative care is more of a team-based approach in which other team members, possibly paraprofessionals, take on other important and helpful functions. Such paraprofessionals are the first responders for patients who screen positive on the PHQ-2 or GAD-2. They administer the appropriate assessment questionnaires. For patients who indicate possible suicidality on the PHQ-9, they make referrals for suicide risk assessments as directed by site leaders. Paraprofessionals avoid making definitive diagnoses. They provide feedback and education to patients on their assessment results and the symptoms and etiology of their possible condition. They educate on and instill optimism for treatment options, medication and counseling, and they assist with referrals for counseling. They conduct behavioral activation, which I'll describe in more detail in a minute. They use motivational interviewing to help engage patients in treatment as much as possible. They have regular follow-up contacts with patients, help keep patients engaged in treatment as necessary, re-administer assessment questionnaires, and alert others on the collaborative care team when patients' responses over time indicate a lack of improvement and a possible need to modify the treatment plan. The collaborative care model also involves adding a psychiatrist to the primary care team. Collaborative care psychiatrists do not see patients. They review progress notes, discuss cases with other team members at regular team meetings, and make recommendations on diagnosis and treatment, especially for patients who do not respond well to initial treatment. Over 100 studies have shown that patients who receive collaborative care have quicker and more complete resolution of symptoms than patients who receive typical primary care for depression and anxiety. As promised, here's more on behavioral activation, in which we attempt to engage patients in behaviors that help reduce the symptoms of their mental health disorder. The paraprofessional first discusses behavioral routines that are most helpful in reducing symptoms. Routines involving exercise, behaviors that support good sleep, also known as sleep hygiene, enjoyable activities, socializing, healthy nutrition, and relaxing activities. Then patients consider what they are already doing in these realms, decide what changes they think would be most helpful, and make concrete change plans. At follow-up contacts, paraprofessionals review patients' progress and help patients optimize their plans as necessary to achieve symptom reduction. Some studies have found that behavioral activation is almost as effective as cognitive behavioral therapy. I like to refer to SBIRT with an expanded scope as behavioral screening and intervention, or BSI. We've talked about how SBIRT can be expanded to address smoking, depression, and anxiety. The components of BSI you see on the slide can be used to address an even larger set of important behavioral and social determinants of health. They can address drinking, drug use, tobacco use, diet, physical activity, and adherence to treatment regimens for a variety of chronic diseases and mental health disorders. They can address mental health disorders beyond depression and anxiety. They can address a variety of important social determinants of health with emphasis on referrals and follow-up. Such a comprehensive BSI program would help primary care settings fully implement the biopsychosocial model of health proposed by George Engel in 1977 and maximize health outcomes and quality of life while reducing healthcare costs. We've covered a lot. Let's summarize. Clearly, the SBIRT framework can be used to address smoking, depression, and anxiety, conditions with substantial and negative impacts. Methods of addressing these conditions are well delineated and backed by lots of research, but sadly not delivered to most Americans. For depression and anxiety, counseling is particularly effective, and the effectiveness of referrals can be enhanced by patient education, motivational interviewing, and access to counselors in convenient and familiar primary care settings. If stakeholders are not excited about SBIRT, they might be more enthusiastic about a program that also addresses smoking, depression, and anxiety. SBIRT can be expanded even further into a comprehensive behavioral screening and intervention model which addresses the full scope of important behavioral and social determinants of health. If you'd like more information on BSI, here are 2 readings. The one on the left focuses on the rationale for BSI and how to plan a BSI program. The other focuses on practical lessons that my team and I learned helping dozens of primary care settings implement SBIRT and BSI. Thanks for watching. Please feel free to contact me with questions. and in people who have